Neomed AI Research Review, the podcast where we unpack recent research with potential implications for neonatal practice. For many years, whole-body therapeutic hypothermia has been a cornerstone of neuroprotection for term infants with hypoxic ischemic encephalopathy, HIE. Yet, evidence for its use in late preterm infants, those born at 33 to 35 weeks, has been limited and uncertain. Today's episode explores the 2025 JAMA Paediatrics Multi-Center Randomized Clinical Trial by Faix and colleagues, titled Whole Body Hypothermia for Neonatal Encephalopathy in Preterm Infants 33 to 35 Weeks Gestation. It's an important study to examine. To begin, why was such a trial considered necessary?
Although clinicians have increasingly applied hypothermia to late preterm infants, previous support came mainly from extrapolation rather than direct evidence. Concerns included a potentially higher risk of adverse events such as intracranial hemorrhage, coagulopathy, or necrotizing enterocolitis in this younger gestational age group. A randomized trial was therefore undertaken to clarify possible benefits or harms.
Who was enrolled?
A total of 168 infants, 33 to 35 weeks gestation, with moderate or severe HIE and less than 6 hours old at randomization.
The interventions?
One group underwent whole-body hypothermia, target esophageal temperature 33.5 degrees Celsius for 72 hours. The comparison group received actively managed normothermia, targeting 37.0 degrees Celsius and specifically avoiding hypothermia.
Primary outcome.
A composite outcome of death or moderate to severe disability assessed at 18 to 22 months corrected age.
And the main findings?
Within the study population, the composite outcome occurred in 35% of infants in the hypothermia group versus 29% in the normothermia group. Mortality alone was 20% in the hypothermia group versus 12% in the normothermia group. Bayesian analysis yielded a 74% posterior probability that hypothermia increased the risk of death or disability and an 87% probability that it increased mortality.
Did the authors explore reasons why late preterm infants might respond differently from term infants?
They proposed several factors: developmental differences in the preterm brain and thermoregulation, differing etiologies of HIE. The late preterm cohort showed higher rates of placental ruption and maternal hypertensive disorders, and technical challenges, such as temperature overshoot. Notably, analyses excluding infants who overshot still showed no benefit from hypothermia.
Strengths and limitations?
Strengths include the randomized, multi-center design, clearly defined criteria, blinded outcome assessment, and active temperature management in both groups. Limitations involve moderate sample size, differential loss to follow-up, greater in the normothermia arm, inability to blind bedside clinicians, and exclusion of 47 otherwise eligible infants whose clinicians opted for non-trial hypothermia.
How did the authors summarize the implications?
From their perspective, therapeutic hypothermia did not demonstrate a reduction in death or disability for infants 33 to 35 weeks gestation with HIE and was associated with a signal towards harm. They emphasized the importance of rigorous normothermia management in the control group and suggested that counseling for families may need to reflect these findings. They noted 3 considerations. 1. Observed outcomes. Within the trial, hypothermia was not associated with improved composite outcomes and showed higher mortality. 2. Temperature management. Maintaining targeted normothermia without hyperthermia formed an integral part of the study protocol. And 3. Family discussions. Differences between term and late preterm physiology warrant clear explanation when treatment options are reviewed.
Looking ahead, the trial raises the question of what alternative neuroprotective strategies might benefit this vulnerable group. Future research directions remain open. Thank you for helping us interpret this data, and thank you to our listeners for joining Neomed AI podcast. Just a reminder, this AI-generated information is for educational purposes only and is intended for trained neonatal clinicians. It does not replace independent clinical judgment. Always refer to the current national and local guidelines.